We're going to go over amniotic fluid, and it's a little short lecture, but it covers the fluid as much as we need to. Amniotic fluid is the fluid that surrounds the fetus during development, and it's meant to be there to protect. There's a lot of different sources, actually, as the fetus develops. The source of the fluid is going to change throughout the pregnancy because, of course, the fetus changes throughout the pregnancy. Very early in the pregnancy, literally in the first months, the amniotic fluid that's produced is actually an ultrafiltrate of the maternal plasma. So it surrounds the fetus, and it's filtered maternal plasma. So much of what you see will resemble the levels of the concentrations of the analytes in the mother. Around mid-gestation, then it starts to change. By mid-gestation, most of the amniotic fluid, it's mostly fetal urine and fluids that have diffused through the fetal skin and from their lungs and such. And that's where mid-gestation on is the more likely times when you're going to get amniotic fluids, because before that, it's really just a maternal product. As you move through the pregnancy, also the composition will change of the analytes. So, for example, in the first trimester, the highest concentrations are of sodium, chloride, and uric acid. That's in the first trimester. Then they lower. The urea and creatinine are lower in the first trimester, which should make sense. Those are waste products. They'll build up as the pregnancy progresses. Okay, so the ions, the uric acid, those will decrease, and the urea and the creatinine will increase. The other thing that happens as you move through the pregnancy is that the particulate matter that's present in the in the amniotic fluid will increase, and that just comes as the fetus grows. It sheds numbers from the tissue surfaces. It still has cells slough off and die, and that's normal. Okay, so this will pick up as the fetus grows, and so it'll get more and more cloudy with particulate matter. It's not until late in gestation that we start to see things, material from the fetal lungs, because the lungs start to be mature. It's one of the last things that matures in the fetus. So there are structures called lamellar bodies, which are from the fetal lungs, which you'll start to see late in gestation. You'll also start to see, it's not shown in this lovely little cartoon here, which looks so pretty, but this fetus is actually covered with a fine, soft hair called lanugo, and that lanugo will shed as the infant nears termination, and so that'll increase the cloudiness of the fluid as well. By the time the fetus reaches term, you'll have these large particles. It's actually called vernix caseosa, and all that is these clumps, sort of epithelial cells that have shed off, and also sebum, the oils and things that are produced by the infant, and those could be present also by term, so close to term at least. One of the things that we occasionally find in the amniotic fluid, which really only occurs when there's stress for the fetus, would be meconium, which is fetal gastrointestinal contents, fetal poop. Okay, it's not supposed to be in the amniotic fluid, and the presence of it is a danger sign for the fetus. You know, there might be some risk of infection, some risk of problems if we find meconium in the amniotic fluid, but more so because it's a sign of stress than anything else. This kind of these contents, what they mostly consist of are the epithelial cells that line the gastrointestinal tract, the lanugo, which was shed, and also mucus and bile. And that's really mostly obviously not eating, it's not normal poop, so it's a little bit different. And it has like a brown-green color, which is how we would know that it's in there. Okay. The purpose of the amniotic fluid, obviously, is to protect the fetus from trauma, as well as infection and temperature change as well. Want to keep all those things consistent because the fetus is not able to protect itself. It's also meant to protect the fetus from umbilical cord compression. In particular, floating free in a fluid environment reduces the possibility that that cord will be compressed and restrict blood flow to the fetus. The amniotic fluid is also going to be a source of fluids, but also nutrients. There are certain nutrients that'll move through the amniotic fluid, and it is a space for the fetus to eliminate waste and some waste, in particular the waste that develop through the lungs. The fetus does breathing exercises, if you will, in the fluids, and the waste is eliminated into the amniotic fluid. The volume of the amniotic fluid should increase weekly, and all pregnancies are based on the week of the pregnancy. So you go through 40 weeks, and at 40 weeks you're considered term. Amniotic fluid volume should peak somewhere around 33 weeks. So after 33 weeks, you're not really going to see a huge increase in amniotic fluid. The child is in the last trimester and is starting to mature the final parts before birth. Now, the actual volumes are going to vary from pregnancy to pregnancy, not just person to person, but also pregnancy to pregnancy. And as all things in pregnancies, we give a 5th, a 50th, and a 95th percentile against which to compare the volumes that we get. So the 5th percentile would be somewhere around 300 milliliters. The 50th percentile would be somewhere around 800 milliliters. And the 95th percentile would be around 1900 milliliters. So even so, it's relatively small amount. At the highest percentile, you're talking just under 2 liters of fluid. When mothers go in for ultrasound, they can estimate the amount of amniotic fluid that's present, and it'll be measured to compare fetal development in general. And if a woman has more than 2 liters of amniotic fluid, that's considered what we call polyhydramnios or hydramnios, either one of those. And really the problem with too much amniotic fluid, that's been associated, they're not sure exactly why it occurs, but the presence of polyhydramnios has been associated with certain fetal malformations, in particularly of the central nervous system or the gastrointestinal tract. So those it's something to note on an exam. Oligohydramnios is different. That's reduced amniotic fluid. What's the main reason for a reduced amniotic fluid? Well, a leak in the woman's the sacs around the baby have bursts at some point or punctured or formed a leak, and so she's losing amniotic fluid, and in that case the pregnancy is in danger. Why would we collect amniotic fluid? Amniotic fluid is collected by amniocentesis. I'm sure you've heard that word, but the process actually has some pretty significant complications that could occur. You do have to penetrate the membranes, so therefore you are risking their primary purpose. The potential complications include infection, premature rupture of membranes, which would mean premature birth, injury to the fetus, and even including miscarriage, fetal loss. So having a reason to collect these things is important. We don't just collect amniotic fluid just because we feel like it. So there are reasons why we might, and those include things like prenatal genetic testing. Now we're not going to cover that here. That's something that will be done through a genetic counselor, but so we don't do that in the clinical lab. But that is a reason why they might collect them. For our purposes in the clinical laboratory, one of the reasons that we would collect amniotic fluid is to determine fetal lung maturity. In a high-risk pregnancy, when you want to see how far along those fetal lungs are, to see if maybe it's okay to undergo cesarean and end the pregnancy, then you determine if the fetal lungs can take the stress. We also do it if we want to identify an infection that might be going on. We used to historically was done to determine the degree of fetal hemolytic anemia, but there are other means of doing that these days. They also do it to test for open neural tube defects or to evaluate the overall integrity of the membrane. The problem with that reason is that you're risking the membrane by doing the amniocentesis. Okay. In the process of amniocentesis, they're going to guide a needle through the abdomen and into the uterus by ultrasound because they need to avoid several things. They need to avoid the maternal bladder. They need to avoid the placenta because that would create a bleed. They need to avoid the umbilical cord for the same reason. And of course, they want to avoid the fetus. If it does need to be performed, that you can see on the chart that there are different weeks where it can, different ranges of weeks where it can be performed. The most common weeks are 15 through 20. Okay, but taking into account the significant risks is something that has to be determined between the doctor and the patient. Now, the first few milliliters that are collected they're most likely going to contain maternal cells. After all, you all have to go through the abdomen and all that stuff. So those first few milliliters will be discarded in order to, prevent any mix-up of, in particular in the genetic studies, we want to prevent that mix-up. And then the total volume collected will be based on the gestational age and how much can be seen to be present on ultrasound. The average volume that we're going to take, if it's taken in the second trimester, will usually be between 2 and 30 mils if that's available and if the test requires it. And it's important to remember that if you have an Rh negative patient, an Rh negative mother, then she should receive RhoGAM before the procedure to prevent against the possible sensitization that can occur if any bleeding occurs across the membranes. This sample here does have to be treated in a particularly special way. It has to be kept at room temperature, and it has to be tested right away. We say within 24 hours, but really has to be tested right away. And remember, if one of the reasons that you are going to do this test is to assess hemolytic disease of the fetus, then you have to protect it from light because bilirubin is what you're going to be looking for. So you remember that bilirubin testing requires that you protect it from light. Cytogenic testing for the genetic counseling, if that's going to be done, you can't freeze or refrigerate the specimen because you can damage the cells. And the same goes for certain lung maturity tests like the lamellar body counts. You can't do that from a frozen sample. So room temperature is ideal. You need to make sure that you protect the specimen from light in case the bilirubin level needs to be done. Unfortunately, one of the things that does happen is the doctor might enter the mother's bladder. And so one of the things that should be done kind of routinely is to differentiate it from urine. Make sure that this is definitely an amniotic fluid and not a urine. The color can be similar in some cases. If you're really far along, in the later trimesters, it'll probably be cloudy enough that you can tell it. But if you needed to differentiate it from urine, do a creatinine level. Check the creatinine level. Make sure, it's not urine. Okay. Now the creatinine level in an amniotic fluid should be close to plasma levels. So if it had much higher levels than the plasma level, you could say, well, this is definitely urine. Okay. Some other tests that you could use, you could do a total protein or a glucose level. Those are considerably higher than normal urine, so that might help too. They do have amniotic fluid does have protein in it, and it does have a certain amount of glucose as well. So you can do those, and as long as the urine is normal, it's not a diabetic mom, you probably do okay using those. Now the gross exam that you're going to be doing, just like in all other body fluids, we give a color and a clarity. And the color, a couple of things that it can do, it can point to the presence of blood. Obviously, if it's red, it likely contains blood, if you see the blood in there. Now, green or brown can mean one of two things. If it's like a green-brown color, like a mixed green-brown color, that might mean meconium. It also might mean that there was a hemorrhage, that there was some kind of bleed that's old now and the blood has lysed or it has aged. And so you get this kind of ugly brownish color, okay? But we do have to mention the color because normal amniotic fluid should be a straw or yellowish kind of color, okay? Now we do not really do microscopic exam with the exception of potentially a lamellar body count. There's not really a lot of value. We don't get cell counts out of amniotic fluid, so this is unique in that sense. Mostly what we want to figure out is if this pregnancy is in distress, if there's a reason why we should allow this baby to be born early by cesarean. That's usually what we're trying to figure out in our clinical lab. And the tests that we're going to use to do that are given in this chart here. You can see some of them down here, like the fetal lung maturity. Those are the key ones that we do, as well as premature rupture of membranes. We want to see if this pregnancy is the pregnancy is ending by premature rupture of membranes, and if the baby is ready to be born without assistance of a ventilator. So these are the tests that you're going to do for that. The lecithin to sphingomyelin ratio, lamellar body count, and phosphatidylglycerol will help us to estimate fetal lung maturity. Rupture of membranes, we look for those markers that are unique to amniotic fluid that are unique. This is actually done in different areas. We can do cultures if we suspect that there's an infection that will require the infant to be born early. And then these are some of the genetic testing. We don't do these in the clinical laboratory, so these would be sendouts. And then one of the other things, these aren't done routinely on pregnancies anymore. They're done usually through the mother, but if in a high-risk baby, you might want an amniotic fluid in order to test for open neural tube defects, so that when the child is born, that you could be prepared for that. And finally, HDN, there are other ways, of course, besides amniocentesis to test for this, but testing a bilirubin level on an amniotic fluid certainly would be a legitimate method. Now, premature rupture of membranes, or PROM, is associated, of course, with increased risk of chorioamnitis, or an infection, or prematurity. No surprise there, as well as an increase in perinatal and maternal morbidity and mortality. We don't necessarily think of pregnancies as being cause for increased maternal morbidity and mortality, but it is. So making sure that we can not only save the child but also the mother is important, and that means knowing that the membranes actually rupture. That's not always obvious. Now, most women are going to be detected, they're going to be diagnosed with premature rupture membranes with a speculum exam, so by their OB in the office and by history. But in about 5 to 10% of all pregnancies, 10% of cases of PROM, we actually can't tell if the membranes are ruptured just by doing a speculum exam. So the gold standard of testing is with what's called the dilute indigo carmine dye test. And in this case, it is done with amniocentesis, and you infuse this dye, this dilute indigo carmine dye, into the amniotic cavity. And if that dye is detected in the vaginal cavity within 30 minutes of the infusion, then you know that you have premature rupture of membranes. The problem with this gold standard test is that it's very invasive because you have to do amniocentesis to do this. So other tests have been developed in order to try and diagnose PROM without actually using amniocentesis. And those ones, they have to be compared, though, to the dilute indigo carmine test in order to, they have to be validated. So one of the things when we say a speculum exam, if you do a speculum exam and you see pooling of fluid in the vaginal cavity, that's a pretty good indication that you've got rupture of membranes. If you do ultrasound and you see there's no fluid left, well, it had to go somewhere. So that is definitely, if you see oligohydramnios or no fluid left, it had to go somewhere, so rupture of membranes. The other thing is you can test the pH of the pooled fluid. That's the nitrazine test, which is just your testing the pH of the pooled fluid that was occurred during that was collected during the speculum exam, and that would help to determine if it's the vaginal cavity is usually somewhat acidic and the amniotic fluid is closer to neutral. One of the things that we have seen in the laboratory is the Fern test. If you take some of that pooled fluid or some vaginal secretions and you place it on a glass slide, when amniotic fluid dries, it has this distinctive fern shape. Okay, this fern drying characteristic, a pattern, that's the word I'm looking for. And you can see this under low power, 10x, you'll be able to see this. Vaginal secretions wouldn't dry this way, saline wouldn't dry this way, anything else involved in the exam wouldn't dry this way, but amniotic fluid would. And so this would be considered a positive Fern test, and you could presume premature rupture of membranes. You could do a pap stain on the fluids that you collected from the speculum exam, and you'll be able to see amniotic cells that would stain a variety of colors, from green to orange to pink, whereas vaginal cells would stain uniformly green or blue-green. So being able to see like this riot of colors would help you to determine, hey, wait, there's amniotic cells in the vagina. They're not supposed to be there unless you've had premature rupture of membranes. And then finally, you have a Nile blue stain. And this is a separate stain that helps to differentiate fetal cells from vaginal cells. The Nile blue stain will stain fetal cells a yellow to orange color, and that's because of surface lipids on those fetal cells, whereas vaginal cells, which are old and dried out, they're blue. So they won't be that yellow-orange color. It's a pretty distinctive color difference, so pretty easy to read. So these are all less invasive tests, but they would be less sensitive than the dilute indigo carmine dye test, of course. The physician and the patient have to weigh is, okay, do I want sensitivity or do I want invasiveness? And that's plus and minus on either side of it. Chemical analysis of amniotic fluids. This is not the same as other fluids because there's going to be significant changes in our expectation based on the gestational age of the infant. Okay, so the concentrations of the analytes are necessarily going to be affected. There's amniotic fluid. While you can have turnover of amniotic fluid, the analytes in it, they're not necessarily eliminated. That's why the fluid gets cloudier. over time. So they will be affected not only by gestational age, but also, well, how much fluid is there, the volume of the fluid. So the concentration that you get has to be related to the total volume of amniotic fluid there. Now, for the most part, we're not going to do the same tests on amniotic fluid that we do on other fluids. We're not doing a glucose level. We're not going to do total proteins, things like that. Mostly what we're looking for here is health of the fetus or the pregnancy, and also lung maturity. Those are the kinds of things that we're looking for. Now, alpha-fetoprotein, or AFP, you've probably heard of that one before. AFP is a protein synthesized first by the yolk sac, and then eventually, as the fetus develops, by the fetal liver. Now, it's not quite known what alpha-fetoprotein does, but it's thought to be a carrier protein in the a fetal carrier protein, kind of like albumin. And what they've noticed is that AFP synthesis increases through the first 9 weeks and then slowly decreases until it stops being produced somewhere around the time of delivery. And then AFP, as it's produced, it'll get filtered out of the fetus by the urine, and it'll end up in the amniotic fluid. So we'll see increases in the concentrations there. They'll mirror the concentrations in the serum as they're filtered out, but it'll be about 2 to 3 times lower if you needed to know fetal AFP levels. There are certain abnormalities of the fetus that demonstrate a drastic increase in amniotic fluid AFP level. And the most common abnormality would be a neural tube defect. So alpha-fetoprotein levels are done specifically to try and predict neural tube defects. Although it's not the only thing that would increase the concentration. Probably the most common thing that would increase the concentration is multiple pregnancies. So you've got twins or triplets or, God forbid, anything else. Okay. Some other things that would increase it, if the fetus dies, loss of pregnancy, the mother is still, actually the pregnancy is still there, but the fetus has died, AFP levels would be very high, as well as certain other abnormalities, like there's a couple of structural defects that are associated with it, some kidney problems that are associated with it, fetal kidney problems that are associated with it. But the key reason to collect the amnio, to do an AFP, would be to try and predict a neural tube defect. The weeks that you do this, screening for a neural tube defect, should ideally be done between 16 and 18 weeks gestation. It can be done between 15 and 25 weeks, but 16 and 18 is the ideal time to do your screening. And the screen is done on maternal serum. And since the levels that, remember, any alpha-fetoprotein in the mother came from the baby, because we don't make alpha-fetal, we're not fetuses anymore. Okay. So what we're looking at is the relative concentration. We're trying to predict what's going on in the fetus. If that screen is off, you might then collect an amnio and do an alpha-fetoprotein on there for a more sensitive test, a more sensitive level. Now, since the levels do vary with time, we need to be accurate as to the week of gestation. And we compare the levels that we get, which are read spectrophotometry. You can see here's the numbers that you get on the spec, and here are the weeks and gestation. Okay, and depending on the weeks, here's 14 to 40, 27 to 40. Depending on the week that you decide to do this, this one here would be, when you get the amnio, maybe this is where you do the screening. You see where the screening is done? 15 and 18 weeks. And what we do in order to relate that level that we get, which can change with the week time, is we express the measurement of the alpha-fetoprotein as a multiple of the median, or MOM. That's just to be cute, I'm pretty sure. And the way you do that is you divide the you divide the individual AFP result by the median AFP concentration for that gestational age, and that's done by day. So you actually have to read these between the weeks. You have to do it literally by the day. Okay, and then whatever week you're in, you find the actual day and you read across, and you get your level. Okay, and what this allows you to do is compare results from lab to lab and to avoid analytical variation because of the different methodologies of testing for AFP. Okay, so their patients can be screened at any lab, and they can be they can feel more confident for the results that they're getting. Now, for most neural tube defects, the cutoff for AFP is 2.0 to 2.5. If it falls above the cutoff, if it falls above that cutoff, likely you would be referred for amniocentesis to get a more accurate AFP result. Okay. And AFP these days is measured on the modern automated analyzers. So while the more methodology might be different on the different analyzers, at least you know that the procedure itself is consistent. Another analyte that we look for in the amniotic fluid is cholinesterase. Cholinesterase is an enzyme that catalyzes the hydrolysis of choline esters. I mean, it's not exactly a brain surgery to figure out what these do. An example is acetylcholinesterase. Acetylcholinesterase is distributed in the gray matter of the central nervous system. Okay, you've heard of it before. It ends synaptic transmissions by hydrolyzing acetylcholine so that the message is not constantly being transmitted. It also happens to be present on red cells, but I'm not quite sure what the function is there. Pseudocholinesterase, another enzyme. This enzyme is found in the white matter of CNS as well as in the blood. They're not sure of the physiologic function. However, it is a marker, gray matter, white matter. Okay. And it is also important in pharmacokinetics, but we don't need to know about that. The key thing is that amniotic fluid normally contains pseudocholinesterase. That should be an amniotic fluid. But it should never contain acetylcholinesterase. So a fetus that has a neural tube defect will have a high acetylcholinesterase level in the amniotic fluid. It's a very good marker for there being some kind of defect. And this is done through gel electrophoresis. You just run the fluid and look for the proteins, the enzymes that are present. Now the acetylcholine will migrate anodally to the pseudocholinesterase, which allows you to really figure it out. One's moving in one direction, the other's moving the other. And then once the two enzymes are separated, you can reveal the bands by incubating that gel with some copper ions and then acetylcholine as a substrate for both. Okay, this test actually, this would not be routine if you had a high risk neural tube defect, right? So the screen was positive, pardon me, and then your alpha fetoprotein was high in your amnio, this would probably be a reflex. So if your alpha fetoprotein on your amniocentesis was high, you'd do the protein electrophoresis to identify acetylcholinesterase in the amniotic fluid, and that would be your confirmatory test for an open neural tube defect. The other chemical that we would look for, that we used to look for much more commonly, would be bilirubin. Bilirubin, which will build up in the amniotic fluid, and it's kind of one of the things that will change the color of the amniotic fluid as the bilirubin builds up. It has that sort of yellowy, goldy, greeny color. It's present in the bile, and it'll build up in in the amniotic fluid. As it builds up, it should peak in the amniotic fluid somewhere between 19 and 22 weeks gestation. Okay, remember, you don't have all the functioning liver. It doesn't all work the same way in a fetus as it does in an adult. So we expect the bilirubin to build up as the fetus goes through life cycles of red cells. And that peak level between 19 and 22 weeks should be somewhere between 1.6 and 1.8 milligrams per liter. Now this milligrams per liter, okay? That's a really low level. So we can't use our standard tests for measuring bilirubin out of amniotic fluid. So instead we use spectrophotometry, direct absorption spectrophotometry, and we set our spec at 450 nanometers, since that's what bilirubin absorbs light best at. And so we can look at the absorbance baseline. If you run the spec between 350 and 550, you can see the deviation at 450, and that deviation in your curve will be proportional to the concentration of bilirubin. Okay, that's called change in optical density at 450 nanometers. And that's why it's called delta OD, change in optical density at 450 nanometers. This was used to help to determine the level of fetal distress in cases of fetal disease of the newborn, hemolytic disease of the newborn. And this has to be interpreted, I used these charts before as if it was for the alpha fetal protein, but it's actually for bilirubin. It's the Lilly chart and the Queenan chart. And you compare, here's your optical density at 450. You pick your week's gestation, because remember the concentration changes. Go up whichever week you are. If you're at 30 weeks, go up what is your change, the difference between the two, and then read across just like you would any other graph. Okay, but the key thing is to know the gestational age. Look at the difference that you could have from 1 week to another. It can be significant. Okay, so this was a common thing, a fairly common thing that was done before ultrasound technology really improved to the level that it is now. And these days, instead of trying to determine how sick the kid is by sticking a hole in the mother, we do Doppler ultrasonography, which is where they use the ultrasound to try and determine the level of fetal anemia. One of the signs of anemia, which you have learned in hematology, is that your heart rate increases, right, to get blood flow moving around the body more. And so, as you may also know, the skull of the fetus is not fully formed. So noting the rate of blood flow in the fetal brain is actually not too hard with ultrasound. You can use your little ultrasound measure wand and measure the peak velocity of the systolic blood flow in the cerebral artery. And if you have increased velocity, the more the velocity is increased, the more severe the anemia is proposed. And this has pretty much replaced amniocentesis for determining the severity of fetal anemia. And the reason is it's so much less invasive. It's so much safer for both the mother and the infant. And so they can determine if this kid's really anemic and we need to either deliver the kid early. They can actually in some places do fetal transfusions. That is possible in some places. That would also be, of course, invasive, but if you want to keep the pregnancy going for longer, then it might be an option. The other thing that we test for, and it usually is done in chemistry, is the pulmonary surfactants. So a pulmonary surfactant is basically they're phospholipids that are produced by the lung tissues, which allow the lungs to remain inflated. It allows them to become inflated. If you think of the lungs as a wet balloon, if you remove the air from a balloon that's wet, the balloon will stick together and it'll actually be harder to get more air into it. So your lungs would have that tendency. If they didn't have these surfactants, which would keep the tissues from sticking to each other, every time you tried to breathe in, you'd have to force air in instead of just drawing it in smoothly into your lungs. And that's what the surfactants are there to do. But since fetal lungs are immature until very late in the pregnancy, these phospholipids, they're not really created until late in the pregnancy. And so measuring the ratios of these phospholipids to each other and the levels of these allows the physician to predict the maturity of the lungs. And lung maturity tests allow us to determine how well will this kid do if they're born. Okay. These are all these phospholipids. They're synthesized by the pneumocytes, and normally they're packaged into storage granules. Somewhere around 25 weeks of gestation, they start being produced, and they're packaged into these storage granules, which are called lamellar bodies. Okay, in what's in that, about 90% phospholipids, about 10% proteins. Okay, the most abundant phospholipids are a phospholipid called PC, which stands for dipalmitophosphatidyl-choline, just know it as PC, or lecithin, which is easier to say. And then the other most abundant one is phosphatidylglycerol, or PG. The other phospholipids present, there are other ones. There's phosphatidylinositol, phosphatidylethanolamine, and sphingomyelin. Okay, these are much less abundant when compared to the PC lecithin or PG. Okay, so lecithin will be detectable in the amniotic fluid somewhere around 25 weeks, and it'll increase pretty steadily until 36 weeks. The PG, or the phosphatidylglycerol, that synthesis doesn't even start until around week 35, and it'll increase until term. So testing all of these levels of the surfactants that are present allows us to determine how mature how mature are these lungs. Will this kid be able to breathe when it's born? And if the levels are low, if the ratios are off, then the child is at high risk for respiratory distress syndrome when they have to be intubated. So it is definitely an important test for premature births. The lecithin to sphingomyelin ratio. This was the first biochemical test that we used for assessing fetal lung maturity. We did it all the time when I was very long time ago in chemistry, and they would do these. We'd get amniotic fluids actually pretty regularly because, well, we still did that, and the Doppler ultrasounds weren't as good as they are now. And so they would rely on this. They do them daily almost for these moms who are at risk and they were up in our OB. And this ratio that you develop, remember the lecithin should be increasing and the sphingomyelin starts out much lower. And so you'll look at a ratio that should change as the lecithin drops off and the sphingomyelin then the relative ratio is higher. So that relative change will occur as the lungs mature, okay? And the way that we do this is basically through thin layer chromatography, okay? The sphingomyelin, the technique for it is to take about 3 to 4 mils of fluid and you centrifuge it at low speed. You don't want to damage anything too much, but you want to remove the debris, all those cells and that lanugo, but you want to maintain the phospholipid content of the fluid. Then you you use the supernatant and you mix that supernatant with some methanol, and then you extract the lipids into a chloroform solution, okay, and apply that to a thin layer chromatography plate. And with controls, you're going to have your controls to show the locations of the various components. That plate's going to be developed in a solvent, which will contain chloroform and methanol, some other things. That's why you don't really need to know that part. But anyway, normal blood has a lecithin sphingomyelin ratio between 1.5 and 2.0. So if your amniotic fluid is contaminated with blood, you can't use it. Same goes for meconium. Meconium has a LS ratio somewhere between 1.1 and 3.6. So you can't use fluid that's been contaminated with that. It has to be clean fluid. And that's it. In that sense. So what we're looking for is if it's less than 2, if that ratio is less than 2, we're thinking that the lungs are not mature. We really are looking for that ratio to increase greater than 2 in order to determine it as mature. If you have a pregnancy with multiple, multiple fetuses, that it only complicates the issues. Okay. Now the lamellar body count will range. This is a second test that could be done. The lamellar body count will range normally. So those are those granules that contain the phospholipids and a little bit of protein, but mostly phospholipids in them. And if you do a count on the fluid, you'll get these different size globules, and there'll be somewhere between 1.7 and 7.3 femiliters, which is it includes the size of a platelet, but it starts much smaller than a platelet. Okay, so the good thing about that is we can actually type in the size range and include it on an automated cell counter. Okay, it allows you to quantify the number of lamellar bodies. You can also use other things. You can use impedance or optical methods in order to do that. These are phospholipids, so you'll start to see some changes in the way the light moves. Okay, so these are all possibilities with the lamellar counts. The key thing is that you need to really treat the sample with kid gloves as you're doing this so that you don't break up those lamellar bodies. Okay, you got to mix that fluid gently, and you got to do. You don't want to do centrifuging because that will lower your lamellar body count. They'll draw it out into the button. Okay. If you have a fluid specimen that's been contaminated with either blood or meconium, if in the case of blood, it'll actually falsely decrease your lamellar body count. And if it's been contaminated with meconium, it'll falsely increase your lamellar body count. So what you're looking for when you do the counts is the 50,000 as your cutoff. And this can change from hospital to hospital. That's a good cutoff. Less than 50,000, not mature. Greater than 50,000, mature. And then finally, the phosphatidylglycerol. Remember, that's not produced until the last basically 5 weeks of pregnancy. And so if you don't detect it in the amniotic fluid, you've got pretty sure that these are not mature lungs. Okay. Now, a fetus under stress will start to mature their lungs at an earlier date. So if the fetus has been, if there's been some stress to this fetus, this whole lung maturity process will accelerate. It'll start earlier. Their, adrenals will kick in and all that stuff. So detecting phosphatidylglycerol in a younger pregnancy allows you to determine, okay, the lungs have matured to a certain extent. And they've developed a slide agglutination test, which allows us, it's pretty simple. It's got an anti-phosphatidylglycerol antibody in it, pretty simple tests. If it's there, it'll agglutinate. And the concentrations of PG are pretty low. So it's And the other good thing is it's not present in either blood or meconium. So if you do have a contaminated specimen, this makes a good marker for lung maturity. So if you have maybe an example of PROM and you've got some fluid that you want to test, doing a phosphatidylglycerol, first of all, you need only a small amount, and you can, it's either there or it's not. If it's not there, lungs aren't mature. There are markers also, other markers, and these are actually meant to be point of care tests done at the doctor's office. And these markers allow the doctor to figure out directly if the membranes have ruptured. However, if you do have an OB practice in your hospital, these are things that you have to help them QC sometimes. So there's some quick and easy tests that can be done. Okay. The first one would be the placental alpha macroglobulin 1. This is a placental glycoprotein, and it's normally secreted into the amniotic fluid at a pretty high concentration relative to the amount found in maternal blood. So in the amniotic fluid, you'll find somewhere between 2,000 and 2,500 nanograms per milliliter, whereas in the maternal blood, there's only about 5 to 25 nanograms per milliliter, so you can see there's a huge difference. So in this test, what we're taking advantage of is that concentration difference. And so you collect a specimen of the vaginal secretions on a polyester swab, and the fluid that's collected onto that swab is eluted off, just usually by using a simple buffer. And then the test strip is placed into that buffer for about 10 minutes, and the result will be determined by, you just got to look for a line. It's just a pretty simple test. So this would be an example of a lateral flow that could be used here. Okay, so this one, you see, here's the swab, you put it in the buffer. In this case, they pour the buffer in here in the sample and they watch it go across. That's how this little kit would work. Then we also have insulin-like growth factor binding protein 1. And this protein happens to be secreted by several tissues in the fetus, and it should be about 100 to more times more concentrated in the amniotic fluid than in the serum. And the same thing, we have lateral flow that uses an antibody against IGFBP, and it would look similar to this. So you collect the vaginal sample, you mix it with your whatever your buffer is, and you pour it in, and it's the same basic principle. Okay, but these would be done in the doctor's office, so you doesn't have to send her to the hospital to figure out if she's got premature rupture. Probably the simplest one is pH test. Okay. It's just very simple swabs. You just put your pH indicators. Again, vaginal secretions, slightly acidic in their nature. Ruptured membranes, those fluids would show more neutral results. And so the doctor would be able to figure out pretty easily if the patient had amniotic fluid present in the membrane, in the vaginal cavity. Finally, and not very commonly, but we do occasionally get amniotic fluids in microbiology for culture. While infections are relatively common, between 1% and 2% of pregnancies, the collection of an amniotic fluid to detect a culture, that's less common. We don't really do that very often. If an infection is suspected, they'll usually treat across the placenta, and then if the child doesn't improve, they could change the antibiotics up, things like that. If you were to do amniocentesis on where there was an infection, the risk of spreading that infection to the mother is pretty significant. So we definitely don't want to stress everybody in this situation. However, if you do have premature rupture of membranes or prolonged labor, those are two very large risk factors associated with infectious conditions. So in those two cases, again, we usually get swabs of wherever they suspect the infection is. We'll get a blood when the infant is born. We'll get swabs when the infant is born from the mother. And usually we look for them that way. However, they can collect the fluid, especially if you know you have premature rupture. Well, you can collect that fluid from the vaginal secretions, and we can do tests on that, okay? Because the things that we find that cause these infections, they're not normal flora, okay? But when we do get an amniotic fluid, we're going to work it up as if it should be collected sterilely, and we're going to work it up for both aerobes and anaerobes. And we have to take into account other organisms that we can't grow in the clinical lab. So if you look at the bacteria, Brucella abortus, which is, it gets its name because it's associated with miscarriages. That is an anaerobe. And then if you look a little bit farther down, you have enteric gram-negative rods and group B strep, as well as Listeria, which is known to cause abortions, spontaneous abortions, as well as Neisseria gonorrhea. Those are the ones that we can grow in the laboratory. Neisseria gonorrhea we can grow, but we usually do the identification through nucleic acid testing, and we can do that at the same time we do chlamydia trachomatis. So those ones are usually done with nucleic acids. Treponema pallidum is the causative agent of syphilis, and we use molecular techniques in order to identify that. The other causes of infection we don't grow in the clinical laboratory. Of course, they're viruses. Now, we can grow them in a viral culture if necessary, but for the most part, we would do molecular testing because it would be much quicker. If you needed to know if there was an infection on a fetus, you don't have 5 weeks to wait. Okay, so we want something quicker. And one of the ones that we do look for frequently in pregnancies is a parasite, and that's Toxoplasma gondii, which is a parasite that women come into contact. We get from the cats, and the most common place to get it is from changing the cat litter because it's spread fecal orally, and it's in the cat's feces. And as the pregnant woman changes it, she gets infected with the parasite. Now, many people have been infected, especially people who have cats, indoor cats, have been infected with Toxoplasma gondii. But it's only if you are first infected while you are pregnant that there's a risk. And there's a risk for malformations of the brain, also the heart, the fetal heart. So those are things that have to be watched if there is an infection during the pregnancy. And that's the same case with all the viruses. Many of us have enteroviruses. Many of us have had CMV. These things are things that you might have come in contact with. But if you are infected while pregnant, it's very dangerous for the infant. So identifying these prenatal care includes identifying historical infections with these, which allows us then to predict your risk for coming in contact with the virus and become infected during the pregnancy.